Good afternoon, everyone. Thank you very much for attending this webinar, courtesy of Johnson & Johnson Vision. I'm going to be talking about the quality of visual function versus measured visual acuity and some pearls for success in premium IOL surgery. So I'm Amir Hamid. I work in London, and I'll go through these topics with you now. As is customary in these talks, we sort of list our financial interests. So this will be the general structure of the talk today. We'll go through my bio, the design of the Symphony and its properties, some of the evidence base for some of my recommendations, the use of the Symphony in special cases, some tips to achieve the best results in terms of spherical targeting, IOL formula and patient selection, and my own list of contraindications. And then there will be an opportunity to answer some questions after. So I'm a consultant ophthalmic surgeon working in independent practice in a dedicated eye hospital in central London. I trained at the Queen's Medical Centre, University of Nottingham, for my medical degree, and then my higher surgical training at the Birmingham Midland Eye Centre. I did a corneal fellowship, a refractive surgery fellowship, a glaucoma fellowship. I am a fellow of the Royal College of Ophthalmologists and am on the specialist register for ophthalmology. I also hold the certificate in laser and refractive surgery in the Royal College of Ophthalmologists. I specialize in mainly cataract surgery, including laser assisted, refractive lens exchange in phakic IOLs, laser refractive surgery including SMILE, and my main area of interest at the moment is presbyopia correction. So we look at the Symphony design and its properties. What we were looking at is the evolution of cataract surgery. So quality of vision has continuously improved with advancement in intraocular lens technology. However, there were some gaps identified. So cataract surgery would traditionally involve removing a cataract and replacing it with a monofocal intraocular lens, which would lead to a loss of accommodation, although distance vision would be very good. Distant objects would be focused clearly, but patients would require spectacles for near vision. And then more recently, bifocal intraocular lenses were used, where you could have two discrete focal points for distance or near. But then it was also understood that intermediate vision became more important, and trifocal IOLs were then developed. Certainly I myself have stopped using bifocal lenses for at least 2 or 3 years now. But these traditional presbyopia correcting IOLs, they provide vision, very good vision, but at distinct distances. For example, intermediate, distant and near, but in between there would be gaps in vision. And there were other compromises like loss of contrast, halos and glare. And of course that sort of discrete versus continuous vision argument that we're looking at. So there was a need for a lens which could produce continuous range of high quality vision with minimal levels of disturbing photic phenomena and high levels of patient satisfaction. So that's what the Symphony was intended to do, to give you a high level of continuous range of vision while correcting presbyopia without the traditional compromises that you would find with bifocal and now trifocal intraocular lenses. So it's a diffractive lens with an echelette design which elongates the point to focus. There's some chromatic aberration compensation to improve contrast sensitivity with a very good diopter range. It's also available in a toric version. So I was involved in the Concerto Study, which was published in the Journal of Cataract and Refractive Surgery. 50 surgeons worldwide were invited to participate. There were 411 patients, all of whom had bilateral Symphony IOL implantation. There was a subgroup of 112 patients who had micromonovision, where the non-dominant eye was targeted at -0.75. And what were the endpoints? Well, the endpoints were visual acuity, spectacle independence, patient and surgeon satisfaction, photic phenomena, and they were measured at 4 to 8 weeks and 4 to 6 months post-surgery. If you look at the patient demographics, there was the micromonovision group and the all-patient group, and you can see they were very well matched. What you must also concentrate on in this slide, even though we talk about emmetropia, we still aimed for the first minus in the biometry for the non-micromonovision group. In the micromonovision group, the myopic target was approximately minus 0.75 in the non-dominant eye. Now, these measurements are in decimal, and you can see in the all-patient group and the micromonovision group, distant and intermediate vision were very, very good. But as you would expect, near vision was much more enhanced in the micromonovision group because of that slight myopic target. In terms of spectacle independence, very high levels of spectacle independence, but slightly higher levels of spectacle independence for near in the micromonovision group, as of course you would expect. Photic phenomena, very low for a premium IOL, extremely low, which was much less than we were expecting. Patient satisfaction scores, extremely high, whether it was the all-patient group or even in the micromonovision group. And would patients recommend the lens to either their friends or family? Again, very high levels of patient satisfaction. Surgeons were happy to use the lens in terms of how easy it was to implant, achievement of target refraction, the visual performance they were seeing in their patients, and overall satisfaction, whether this was in the all-patient group or in the micromonovision group. So, in summary, the visual results were excellent. There were minimal photic phenomena, high levels of spectacle independence, high patient satisfaction, and surgeons were very, very happy with this as well. Now, I'm going to go through my own personal experience of a comparative retrospective review. Now, I've been using this lens since May 2014, prior to its worldwide release. I implant up to 100 Symphony lenses a month, and like I said, I was part of the Concerto Study group. Until recently, I was the medical director of Optimax, which has the world's largest database of Symphony eyes to date. So I'll just show you a video of one of my first patients treated with the Symphony lens.
A Kent woman who hasn't been able to see clearly without glasses for 20 years now has perfect vision after having the lenses in her eyes replaced with artificial ones. Nicola Ellen from Wingham near Canterbury is one of the first in the country to undergo the procedure, which helps the eye to focus on both near and far away objects.
Now, the operation cost £5,000. It's not yet widely available on the NHS, but Mrs. Ellen says that the effect on her has been little short of miraculous. John Hunt reports.
Mrs. Ellen hasn't been able to do this for a long time. She says she used to have 30 pairs of glasses, correcting both her short and long-sightedness. Within hours of having an intraocular lens implant, she regained the freedom and vision of her youth.
I could read the newspaper, I got out a telephone directory, and I could read the telephone directory. It felt like a miracle, and that was just with having one eye operated on.
Mrs. Ellen had her second eye treated a week later. She can now both read and see distant objects without glasses.
This is the AMO Symphony Extended Range of Vision lens, which gives you seamless, high-quality vision from distance to near.
Amir Hamid carried out Mrs. Ellen's surgery in Maidstone, implanting the tiny device in her eyes. The implant replaces the failing natural lens within the patient's eye. The surgery takes just 20 minutes per eye and is carried out under a local anaesthetic. The procedure is nothing new, but previous artificial lenses have had limitations, correcting vision for near distance or long distance only, not both. The new design enables the eye to focus at both near or far objects seamlessly.
It gives you the all-round ability to function visually as you would have done when you were much younger and independent of your spectacles.
Nicola Ellen paid £5,000 for the treatment, as it's currently only available privately. She says it has been liberating. John Hunt, BBC South East Today at Wingham, near Canterbury.
So as you can see, one of my first patients had excellent visual function, able to thread a needle with rapid visual recovery. As I said before, my group has produced or helped to produce and involved in publication and presentations of several studies with regards to Symphony, both on its own and comparatively. So if I go through the retrospective review that we did, a comparative study that we presented at the ESCRS in Barcelona in 2015, involving 250 patients, 500 eyes of these patients, 8 surgeons, 250 eyes in the Symphony group and 250 eyes in the at-LISA trifocal group. As you can see from the patient demographics, very evenly matched groups. Patients were slightly on the younger side because they are predominantly refractive lens exchange patients rather than cataract surgery patients. And as you can see, unaided binocular near vision was comparative between the Symphony and the at-LISA trifocal. You must also notice that we aimed for minus 0.25 in both eyes for this result to hold through. Intermediate vision was maintained with a slight myopic target, and there was no sacrifice of distance vision either. So what we concluded from our own data was that both lenses performed very, very well. With emetropia as a target, the at-LISA provides better levels of both uniocular and binocular near vision, but the Symphony achieves higher levels of uncorrected uniocular and binocular distance and intermediate vision. And the Symphony was also extremely tolerant of defocus. We take advantage of this by aiming for low myopia in both eyes, and that will achieve good levels of distance, intermediate and near vision compared to the at-LISA. Patients will achieve high levels of visual performance and spectacle independence when this target is achieved. So we looked at trying to repeat this study in a prospective manner because the retrospective review, the data was not consistent with the Concerto study. We did not have any patient satisfaction data. There was no dysphotopsia data, no defocus curves, and no contrast sensitivity data. So that's why we decided we'd perform a comparative study in a prospective manner. Again, we looked at 3 types of lenses: the Symphony versus the at-LISA trifocal and the fine vision, and they were all refractive lens exchange patients, not cataract surgery patients. What we looked at was monocular and binocular uncorrected distance, intermediate and near visual acuity, photic phenomena rate, spectacle independence, and patient satisfaction. I include the reference for the peer-reviewed publication at the bottom of the slide for your attention. We've gone through the design of the Symphony already earlier on in the presentation. The at-LISA trifocal has 3 points of focus with a near and intermediate ad. It's a plate haptic lens. And similarly, the fine vision has a stronger near ad with an intermediate ad as well, with a very good dioptric range. When we look at the patient demographics for the 3 groups, again, very similar, slightly on the younger side because they were refractive lens exchange as opposed to just cataract surgery. Now looking at the results, again, this is presented in decimal. We're looking at corrected and uncorrected distance visual acuities which were very well maintained in all 3 groups, but the Symphony was better. Intermediate vision was better in the Symphony, and as you expect, the trifocals did perform slightly better for near vision. However, this was aiming for emetropia, but even with a 0.63 decimal, that's approximately N6/N8 vision, so sufficient for patients to read a newspaper at a comfortable distance. What was more impressive was, of course, the fact that contrast sensitivity was maintained significantly with the Symphony compared to the other trifocals. And of course, the levels of dysphotopsia were much higher in trifocal lenses versus the Symphony, as you can see from this slide. Spectacle independence was very high for all three lenses at distance, and also for intermediate vision. Slightly lower for the Symphony, as you would expect, but still at a very high level. This is where the slides get interesting. So despite a high level of spectacle independence, patients were not happy in the trifocal group, and they would not perhaps choose the same lens again. So although all three lenses produce excellent measured visual acuity results and high levels of spectacle independence, there's a high level of distance and intermediate visual acuity with the Symphony. The trifocals no doubt will give you better near visual acuity, but there's a higher level of dysphotopsia and lower levels of contrast sensitivity. Now, what can happen is these can then contribute to patient dissatisfaction despite good spectacle independence rates. In addition to using the Symphony in straightforward virgin eyes, I also use the Symphony lens for post-LASIK cases, patients with mild amblyopia, patients with large pupils, with some levels of ocular comorbidity, and occupational night drivers. In terms of post-laser vision correction patients, I ensure that they have very realistic expectations. There are certain rules I adhere to. I make sure that they have normal topography, no irregular astigmatism, no significant higher order aberrations. They did not lose any best corrected visual acuity, post-laser vision correction, and they had sufficient corneal pachymetry for LASIK enhancement post-operatively. So like I said before, make sure that there's no significant higher order aberrations, and although you can see a myopic ablation here, it's relatively normal topography. I like to use the ASCRS calculator, and I choose the average of the no prior data calculation formula only, which is on the right hand side of the column there. I find this gives the least level of mean absolute error rates post-operatively. So as you can see, post-LASIK Symphony results, very good levels of distant, intermediate, and near vision. Not as good as virgin, unoperated on eye before, but you would expect that. Having said that, with realistic expectations, you get very, very satisfied patients. So what can we do to optimize our results? Well, spherical targeting is important, and I show you this very, very, very busy slide, but it looks at a retrospective review of about 700 cases and what patients achieved in their spherical equivalent post-operatively. And as you can see at the peak of this bell curve, when they achieve from 0 to minus 0.25, there's the best combination of distance and near visual acuity, and that's why I aim for minus 0.25 in both eyes in my patients. What else can you do? Well, it's versatile. It's a tolerant lens, so you can induce more myopia for closer reading vision if required. So what you would do, one of the strategies would be to operate on the dominant eye first to give them the best distance vision and intermediate vision, and gauge what the level of near vision is at that time. You can then use more micromonovision to improve their near vision without compromising their distance or intermediate vision at that stage. What IOL formula do I use? Well, that is easy. For an average eye, it's very easy to choose. Most of the IOL formula will work. The newer generation formula are much better for extremely short or extremely long eyes, and you can see a lot of this information on Dr. Hill's website, which I commend to you. So, patient selection, perhaps the most crucial part of any premium IOL surgery. Your patients have to be realistic. we can never guarantee them that they will have 100% spectacle independence rate. The aim is to reduce spectacle dependency, but the guarantee is not complete spectacle independence. The majority will be spectacle independence, but there's some that will not be. For me, one of my strategies is to offer both an extended range of vision lens and also a trifocal lens to my patients, and I explain the differences between the two in terms of continuous range of vision, contrast, dysphotopsia, and near vision, and we go through what level of spectacle independence they require, what lifestyle, what occupation they do, their general health and their ocular comorbidity, and what the potential visual performance is after. At the end of the day, I would like them to choose which lens they have, and I just guide them through this selection. So there are some contraindications. So if there's very poor visual potential, poor visual quality postoperatively, which can be predicted with significant higher order aberrations, dry eye, irregular topography, they have a very large angle kappa, they have problems with phorias. If you cannot center the lens properly because of zonular weakness or instability, and perhaps crucially, unrealistic expectations and mental health issues, these patients will never be happy despite the best outcomes, despite the best surgery. So in summary, it's now FDA approved since last year. It's high quality, provides continuous vision at all distances without most of the compromises of traditional multifocal intraocular lenses, and very high levels of contrast sensitivity is maintained. So there's a lower incidence of dysphotopsia and has good low light performance. It's robust and forgiving, and it has an extended range of vision. Thank you very much. This is an opportunity for me to answer any of your questions. The first question from Pritesh 2 minutes ago, as compared to Symphony, what are the drawbacks of a trifocal? Well, I want to be very clear. I offer both types of lenses to my patients. They both offer good levels of visual function, but there are some patients that would do better with a Symphony than a trifocal. Those that perhaps drive a lot at night, intolerant of glare and halos, want to maintain high levels of visual acuity, want a continuous range of vision rather than gaps in their visual function. So there's a question from Girish Jethwa. What is a spherical aberration range to select a patient for a Symphony? Well, it's important not to have significant amounts of positive spherical aberration. Really important not to treat patients that have had significant spherical aberration post-hyperopic LASIK, because this does not tend to give good results. Dr. Mahendra Desai has asked what's the post-op refraction we should aim at while selecting IOL power. So earlier on in the presentation I showed you that bell curve of our retrospective review, where we found that if we achieve minus 0.25 in both eyes of our patients, that would give you the best combination of distance and near vision without compromising distance, intermediate, and near vision. So Shroff Charity Eye Hospital, how dense amblyopia is conjugated for Symphony lenses? I think that's an interesting question, and that's what you have to decide for yourself. My cut-off point is usually around 612, 0.5 decimal or 69. One way I've gotten around that is if they have different levels of amblyopia, I might place a monofocal lens in the very densely amblyopic eye and the Symphony in the better seeing eye. The question is, how long will you wait if the patient has halos before intervention or adaptation? I would say you need to give them at least 3 to 6 months for adaptation. The most important thing to tell them is everyone gets dysphotopsia, whatever IOL you use. There are lower levels of dysphotopsia with the Symphony, and most people, as long as they know to expect it, they will be extremely tolerant of it. Does Symphony reduce cylinder powers, or do we need to go for toric IOL implantation? The Symphony can tolerate up to 1 diopter of astigmatism, and that's fine for distance vision, but that can compromise near vision. So I prefer, in my own practice, to use the toric lens as much as possible to ensure that there's less than 0.75 diopters of astigmatism in my patients. In terms of the toric Symphony, I make sure that the lens is rotated to 10 degrees just before the axis IN10, remove the viscoelastic, and then rotate it to its final intended axis. But you must remember that the Symphony unfolds quite slowly, so ensure that it's completely unfolded before you finish your rotation. Otherwise it will rotate as your instruments leave the eye. Would you recommend Symphony for clear lens extraction if the patient is not suitable candidate for LASIK? Well, all the patients that I presented today were clear lens extraction patients, so yes, I think I would. In the case of control glaucoma, is Symphony advisable? We have implanted Symphony lenses in patients with glaucoma. Again, that is something that you decide what your comfort zone is, and you need to have a discussion with your patient as to what the intended benefits are and the guarded prognosis that may give you. So how superior was the near vision with Symphony compared to a +3 ad multifocal? If you refer to a bifocal lens, I've stopped using bifocal lenses already because patients do need to have intermediate vision in this day and age. You can see that the Symphony can give you good levels of near vision, provided you aim for low levels of myopia. Do we need to measure angle kappa pre-op? Yes, we do. We have to treat these patients as refractive candidates, not as just cataract surgery candidates. They are refractive patients, and that's when you get the best results. If you were working them up as though you were going to do LASIK for them the next day, that's how you would work them up for a Symphony or any premium IOL. There's a question here about the use of Symphony in pediatric cases. I'm not a pediatric surgeon. I don't operate on children, so that's not something I can answer for you. What are the probable factors which trigger glare problems? Well, the most common causes of glare are abnormal topography, patients with significant dry eye, and of course defocus. If you have a significant refractive error postoperatively, that causes defocus, and that causes more glare and halos as well. So that's something you need to be aware of. What is my experience with the Panoptics? Yes, I have used the Panoptics. I get this question about superiority. You're asking me, is the Panoptic superior to the Symphony or vice versa? It's not a question of superiority. It's a question of whether you're looking at quality of vision at a continuous range, or discrete levels of good vision at 3 main points in a trifocal, with the association of potentially more glare and halos. And that's something that you have to decide which is your best choice for each particular patient after discussing that with them. Would I recommend Symphony to one-eye patients? I have used the Symphony lens in one-eyed patients, and they've had very, very good results. It is a long consultation process, and I tend to discourage them from having a premium IOL, if at all. But I have had several patients who, despite that, wanted to have it done, and I have done that, and the results have been good. They've had extremely good visual performance for distance, intermediate, and near. I would only use the Symphony lens as a premium lens in this category of patients, as opposed to a bifocal or trifocal lens. What's the best age group to go for Symphony? I don't have a particular age group that I use a Symphony or not use a Symphony. Any candidate that is suitable for refractive lens exchange or cataract surgery who does not fulfill my contraindication criteria, I will offer them a Symphony lens. How do you reassure patients with dysphotopsia? Well, this is really important. The important thing is to tell them before surgery that they will have dysphotopsia. And In most symphony patients, they won't, but in those that do have this photopsia, they will find that it's not a surprise. And similarly, in the trifocal groups, you tell them they will have this photopsia. When they do have the photopsia, they're not surprised, and either they get used to it, or potentially, if it's very severe dysphotopsia, you may have to consider performing an intraocular lens exchange. But in the symphony group, you can see the level of dysphotopsia is exceedingly low, and I've never had to do an IOL exchange for a symphony lens. My experiences with the symphony lens in post-LASIK patients, well, it's very good. The results are very good. We presented a poster at the ESCRS in Copenhagen last year. It was nominated for the poster prize. I think if you log into the ESCRS website, or if you email me, I'm happy to present that data with you in greater detail. But yes, the results are very good. What is my opinion on Symphony for diabetic retinopathy patients? I tend not to implant any premium IOL in patients that have established retinopathy. So that's my recommendation. Does measuring corneal aberration preoperatively help to avoid post-operative complaint of glare? Absolutely, absolutely. You must measure corneal aberrations. Patients with significant levels of corneal aberrations preoperatively will not do well with a premium IOL, even if it's a Symphony post-operatively. Not just with glare and halos, but quality of vision, contrast, all those sorts of things. So that's really important. So I'd like to summarize the key points here. What we're looking at is trying to move away from just measuring visual performance with our standard measurements of visual acuity, being able to read things at a certain distance, but looking at quality of vision, quality of visual performance, extended range of vision, maintaining of contrast, low levels of dysphotopsia, and patient satisfaction. And that should guide you as to what type of intraocular lens you should use for your premium patients. Thank you very much for your attention.